Distinguished colleagues and experts, I am Dr. Xia Xiaoyu, Associate Professor and Deputy Chief Neurosurgeon from the Chinese PLA General Hospital. It is my great honor to share our team's clinical explorations in spinal cord stimulation therapy for spinal cord injury rehabilitation through this virtual platform. My presentation is divided into three main sections. First, I will briefly introduce spinal cord stimulation therapy and the characteristics of China's domestically developed SCS systems. Second, I will provide an overview of the clinical applications of SCS. Third, we will focus on sharing China's experience in using SCS for post-spinal cord injury rehabilitation. First is Part 1, an introduction to spinal cord stimulation SCS therapy and the characteristics of China's domestically developed spinal cord stimulation systems. Spinal cord stimulation is a well-established therapy with a substantial clinical history. It was first approved by the US FDA in 1989 for refractory pain and has been used in over 100,000 implant cases across Europe and North America. SCS was introduced to China in 2003, but its widespread adoption faced significant limitations due to reliance on imported devices and high costs. Since 2021 to 2022, the development and launch of domestically developed SCS systems have significantly advanced the technology's adoption nationwide. In 2024, Ruishen'an SCS has been approved for market launch in Russia, which is expected to facilitate the technology's expansion in the Russian market. SCS is a procedure in which electrodes are implanted in the epidural space of the spinal canal or near peripheral nerves. Through an internal or external stimulator, electrical pulse signals are emitted to stimulate the dorsal column of the spinal cord, spinal nerve roots, dorsal root ganglia, or peripheral nerves, thereby regulating nervous system function and treating diseases. China's domestically SCS systems have achieved technological advantages through late mover innovations. Firstly, these systems offer a wide variety of electrode types to meet diverse clinical needs. Secondly, they support multiple programmable stimulation modes, including low frequency, high frequency, ultra high frequency, burst, and variable frequency stimulation, as well as cycle modes, timed modes, and postural responsive modes. Thirdly, the systems feature dual mode communication, proximal communication for reduced power consumption, and Bluetooth communication. Fourthly, they incorporate remote adjustment capabilities. Both physician and patient programs can connect via Wi-Fi for real-time parameter optimization, significantly improving post-operative follow-up efficiency and reducing healthcare costs for patients. In Part 2, I will provide a brief overview of the current clinical applications of spinal cord stimulation. The core and primary indication for spinal cord stimulation is pain management. Through clinical practice, we have observed its multiple effects, including analgesia, vasodilation, modulation of the sympathetic nervous system, alleviation of muscle spasms, promotion of neural regeneration, and enhancement of motor function. Building on these effects, SCS is now applied in treating refractory angina, managing peripheral vascular disease, promoting consciousness recovery in chronic brain injury patients, improving orthostatic hypotension, enhancing gait rehabilitation in movement disorders, post-spinal cord injury rehabilitation, and post-stroke recovery rehabilitation. Although the detailed mechanisms of spinal cord stimulation in treating spinal cord injuries remain incompletely understood, researchers widely attribute its therapeutic effects to neuroplasticity. SCS enhances the excitability of residual neural connections, promotes axonal regeneration, and restores cortical spinal and sensory motor communication capabilities. These restored pathways are further strengthened through sustained rehabilitation training to maximize neuroplasticity. Additionally, SCS alleviates symptoms and enhances recovery by suppressing pain and improving spasticity. Spinal cord injury results in multidimensional complications beyond paraplegia and motor dysfunction. Patients often suffer from neuropathic pain, muscle spasms and atrophy, reduced strength and sensory deficits, bladder and bowel dysfunction, sexual dysfunction. These issues frequently lead to anxiety, depression, and social isolation, severely impacting quality of life. Spinal cord stimulation addresses these challenges through multimodal mechanisms: pain relief via A-beta fiber activation, spasm reduction through GABAergic modulation, prevention of muscle atrophy via enhanced neuromuscular activation, improved bladder and bowel control by sacral nerve modulation, functional recovery through neuroplasticity. By simultaneously targeting multiple systems, SCS achieves the comprehensive rehabilitation that transcends the limitations of conventional therapies. Next, we will focus on sharing China's clinical experience with spinal cord stimulation in post-spinal cord injury rehabilitation. Our work builds upon global experience, particularly the pioneering research by the Lawson team in Switzerland. In 2018, a landmark study demonstrated that spatially targeted spinal cord stimulation of lower limb motor neurons, combined with temporally coordinated muscle activation, enabled 3 individuals with chronic paraplegia to regain walking ability under gravity-assisted training. Building on this, a 2022 study utilized customized SCS electrodes and optimized placement strategies, developing a software platform for spatial temporal stimulation sequences. This innovation restored independent mobility in 3 complete spinal cord injury patients. Notably, both studies relied on pre-programmed stimulation patterns rather than patient-initiated motor intent. The 2023 breakthrough introduced a brain-spinal interface for SCI rehabilitation. Epidural electrode arrays implanted over the sensory motor cortex recorded ECG signals, which were processed by a wearable unit to predict movement intentions. These predictions dynamically adjusted SCS parameters targeting the lumbosacral spinal cord's dorsal root entry zones, enabling natural leg control during standing, walking, stair climbing, and complex terrain navigation. Here, SCS itself has become a critical assistive component within the brain-spinal and muscle interface system. Next, we will present clinical cases to illustrate the current status of spinal cord stimulation for spinal cord injury in China. While outcomes may not yet match the groundbreaking results reported in research settings, our clinical progress demonstrates tangible benefits for patients. The first case involves a 16-year-old female with complete T12 spinal cord injury, ASIA grade A, caused by a car accident. Pre-operatively, she presented with sensory loss, bowel and bladder incontinence, and paraplegia. Physical examination revealed iliopsoas and quadriceps muscle strength at Medical Research Council grade 1, or other lower limb muscles at MRC grade 0. Sensory deficits below the L1 level, and non-functional anal sphincter. During surgery, a 565 electrode array was implanted at the T11 to L1 spinal segments. Intraoperative stimulation mapping was conducted to identify optimal activation points that selectively targeted the lower limb gait-related muscle groups while minimizing unintended muscle activation. The rehabilitation protocol integrated spinal cord stimulation with robotic exoskeleton training. We developed an exoskeleton SCS synergy program, delivering 30 minutes to 1 hour daily sessions where SCS parameters were synchronized in real time with the exoskeleton's gait cycle to reinforce neuromuscular coordination. Outside training hours, scheduled SCS programs were activated to enhance motor recovery, sensory feedback, and bowel bladder function. Through this multiple modal approach, partial restoration of voluntary leg movement was observed after 6 months of therapy. Post-treatment functional assessments revealed significant improvement. 1 month post-operatively, the patient achieved MRC grade 4 strength in the iliopsoas muscles and grade 3 in the quadriceps, enabling assisted standing and walking. Her ASIA score improved from grade A to grade C. Video documentation across preoperative, immediately postoperative, 1 month and 5 months postoperative intervals virtually demonstrates the patient's dynamic recovery of walking ability.
他右腿有，但是左腿现在还。
咱们现在就不做单腿了，就做连续。
肯定要做连续。
Case 2 involves a 71-year-old male with a 10-year history of recurrent spinal anterogenous cysts requiring multiple surgeries. Following his final cyst resection surgery in 2021, he developed sensory abnormalities and loss below the sternal angle. Despite preserved limb strength, progressive spasticity, joint dysfunction, diminished anal reflexes, and positive bilateral pathological reflexes resulted in deteriorating ambulation, ultimately confining him to wheelchair dependence. We implanted a 565 electrode array at T12 to L1 under intraoperative neurophysiological guidance, primarily targeting lower limb spasticity reduction and motor enhancement. Post-operatively, immediate spasticity relief enabled early assisted ambulation with a walker. By 3 months postoperatively, the patient achieved unassisted walking, demonstrating significant functional recovery. Case 3 involves a middle-aged female who developed lower limb spasticity and neuropathic pain following thoracic spinal tumor resection. She maintained a long-term state of lower limb tightness and flexion, unable to stand or walk. A 565 electrode array was implanted epidurally at the T10 to T12 levels. Stimulation initiated the following day achieved remarkable spasticity and pain relief, with dramatic pre-post video comparisons of lower limb mobility. However, due to the absence of structured rehabilitation, symptoms recurred during follow-up. As parameter adjustments intensified, the patient's psychological state transitioned from initial excitement to frustration, with progressive decline in treatment compliance, ultimately leading to suboptimal outcomes. This case highlights 2 critical lessons. First, SCS must be integrated into a comprehensive rehabilitation framework rather than used as a standalone solution. Second, psychological support is very important and essential. Case 4 involves a 19-year-old male with T6 to T8 spinal cord injury sustained 1 year prior due to trauma. Clinical evaluation revealed grade 4 hypotonia with involuntary lower limb spasms, complete paralysis, MIC grade 0, sensory diminishment. The patient also suffered from pain. To address these multi-system complications, 2 242 pedal electrodes were implanted intraoperatively at the rostral and caudal boundaries of the injured segments, guided by electromyographic mapping. 5 days post-operatively, stimulation was started, achieving immediate resolution of neuropathic pain and hypotonia reduction to grade 1 of left limb and grade 1 plus of right limb. The restoration of working ability in spinal cord injury patients remains the most compelling focus in research. While there are successful cases, achieving this goal clinically remains challenging. Our observations show that SCS can enhance ambulatory capacity in patients with limited mobility, while simultaneously controlling SCI-related symptoms such as pain and spasticity, thereby facilitating more effective rehabilitation exercises. These findings have profoundly motivated our team. As a promising therapeutic tool, we hope to collaborate with more peers to expand the application of SCS, accumulate robust clinical evidence, and ultimately benefit a broader patient population. Thank you for your attention.